This is the first of two webinars about lower limb anatomy. In this webinar we're going to be looking at the neurology of the lower limb, and we're also going to be looking at the hip and the thigh. Let's start off by looking at the nerves as they arise from the spine in the lumbar and sacral plexuses. So first of all, in this diagram we can see the pelvis, L5, L4, L3, L2 and L1. And we have all the roots emerging from the intervertebral foramina. And we're going to look at four particular nerves. So counting up from L5, 4, 3 and 2, from L2 and L3, and if we pick out the colour here, coming from L2 and L3, we've got the lateral cutaneous nerve of the thigh, passing under the anterior superior iliac spine, just under the inguinal ligament, before passing down to the lateral side of the thigh, and it's a purely cutaneous nerve responsible for an area of sensation. We're now going to go to the femoral nerve. That's this big nerve here, and this has roots from L2 right up here, L3 and also L4. And that's the femoral nerve passing under the inguinal ligament and into the anterior compartment of the thigh. It's both a motor for the quadriceps and has a large sensory innervation. And from exactly the same roots, L2, L3 and L4, we've got the obturator nerves. It's a smaller nerve, passes more medially to the brim of the pelvis. It runs along the brim of the pelvis before disappearing down inside the pelvis and coming out through the obturator foramen and going down into the medial compartment of the thigh for the adductor muscles. So that's the obturator nerve. And the fourth and very important nerve that we must talk about is the sciatic, which has roots from L4 to S3. Here we have L4, L5, S1, S2, S3, and going down to the back of the pelvis, to the back of the thigh, and appearing down here and running down in the back of the thigh, and that's the sciatic nerve. Let's look at the progress of the femoral nerve after it's gone under the inguinal ligament. We pick it up here, coming down in the front of the thigh, giving off branches to the quadriceps muscle, also to the sartorius, it also gives off cutaneous branches which are responsible for the anterior and medial sides of the thigh, and its final terminal branch here is the saphenous nerve, which is a long nerve which runs down medially and provides sensation over the medial part of the lower leg. If we pick up the obturator nerve, after it's passed through the obturator foramen, we pick up its colour in the medial aspect of the thigh. It's responsible for the innervation of the big adductor muscles, adductor magnus, adductor longus, adductor brevis and gracilis, but also a small area of cutaneous sensation on the medial aspect of the thigh. So that's the obturator nerve. Let's pick up the sciatic nerve as it runs down the back of the leg. Let's pick up its colour here, runs down the back of the thigh, responsible for the hamstring muscles, the flexors of the knee, and it divides just above the popliteal fossa into the tibial and the common peroneal nerves. The common peroneal runs laterally before going around the neck of the fibula, and the tibial goes straight down to the medial side of the foot. So that's the common peroneal and the tibial nerves, and we're going to be meeting them a lot as we go ahead. Another nerve, a sensory nerve we need to be aware of, is the sural nerve. It has a slightly complicated origin. If we bring out the tibial nerve and the common peroneal and look at two particular branches, let's pick up the medial surocutaneous and the peritoneal and the peroneal anastomotic nerve. We don't need to remember those names, but they both originally come from the sciatic, and a branch from each of those combines. If we pick them up more superficially here in this diagram, we can see them combining to become the sural nerve. It's a purely sensory nerve, it's a long nerve, sometimes used for nerve grafts, and runs down right the way down the leg to go to the lateral side of the foot, to the base of the fifth toe. If we return to the common peroneal nerve as it goes round laterally round the knee, round the neck of the fibula, it divides early on into the superficial, which is lateral, and the deep peroneal nerves, which runs anterior to the interosseous membrane with the anterior tibial artery before passing under the flexor retinaculum into the dorsum of the foot. The other branch, the superficial peroneal, runs laterally and supplies the muscles in the lateral compartment. Now that we've described the main nerves of the lower leg, let's look at the sensory areas they're responsible for. First of all, the lateral femoral cutaneous nerve is responsible for this large area on the lateral side of the thigh. The femoral nerve has a large area of cutaneous responsibility in the front and the medial aspect of the thigh, and as its continuation, the saphenous nerve, it provides sensation in the medial side of the lower leg. The sciatic nerve runs down the back of the leg, dividing into the tibial and to the common peroneal. There's no sensory area from the tibial nerve that we can see from the front of the leg, but the common peroneal, there's an area shown in blue here which has direct innervation from the common peroneal, and then from the two terminal branches. The deep peroneal has a tiny area just between the first and second toes, and the superficial peroneal when we focus in, we can see the deep peroneal area, and the superficial peroneal takes this yellow area here, and the very final bit of the foot that we can see anteriorly is the sural nerve S1 and S2 on the lateral border. If we look at the back of the leg, there are some areas that get innervation directly from the sacral plexus up around the buttock, and we're not going to talk about those, but we're going to talk about some other areas. Some of them we've already covered. Red area at the top is the lateral femoral cutaneous nerve, and the red area at the bottom is the saphenous nerve. Yellow is part of the femoral nerve, and red at the bottom here is part of the saphenous nerve. Those are both from the femoral origins L2, 3 and 4. From the sciatic nerve we've got the first branch of the common peroneal and then its superficial peroneal branch here shown in yellow. And then from the tibial and the common peroneal we've got the sural nerve that we described earlier, and here it is providing this purple area down the back of the leg and round the outer side of the foot, down to the fifth toe. And there's just a small area that's supplied by the tibial nerve underneath the sole of the foot, and we'll look at that in more detail in the next image here. There's a direct tibial area around the heel, and then two terminal branches, the medial and lateral plantar nerves. These are responsible for the sensation of the rest of the sole. And there's a division between these running through the middle of the fourth toe. If we look at cutaneous sensation in terms of dermatomes, we get the pattern that we see here. In fact, there's a lot of variation between individuals, but these are roughly the dermatomes on average, apart from the thicker lines, which are the fairly constant areas. Look at the common pattern, L1 at the top in red, blue, L2 in blue, green is L3, medial side of the knee, L4, medial side of the shin, L5, lateral side of the shin, and S1, the lateral surface of the foot, and up around the heel and up the back of the lower leg. And then above that we've got S2, and then S3, and then S4, before finally we have S5 around the anus. Now let's move on to the femoral triangle. And in this diagram, the femoral triangle has been picked out in light brown. The base of the triangle is the inguinal ligament. The lateral border is the medial border of sartorius. And the most medial border of the triangle is actually the medial border of adductor longus, which you can just see in the triangle. You can just make out the writing of adductor longus. If we look at the base of the triangle, which is of course at the top of this image, we can see the femoral artery in red. Now the femoral artery is said to mark the midpoint of the inguinal ligament. So that's midway between the anterior superior iliac spine laterally and the pubic tubercle medially. And that's a palpable point, the pulse of the femoral artery, and that marks the midpoint of the base. Medial to the femoral artery is the femoral vein, and lateral to it, in yellow in this picture, is the femoral nerve. And one way that I remember the femoral vein being more medial is that if you ever actually have to take blood from the femoral vein, which you occasionally need to do if you've got nowhere else to access, then what you do is you feel the femoral artery pulse, and from the lateral part of the patient, you actually have to reach over the artery in order to get blood from the vein. So that's how I think of it. So the vein is medial to the artery, and then the femoral nerve is more lateral. If we focus on the femoral vein, we can see that a large branch comes into it just at the top of the picture, just before it goes under the inguinal ligament. And that's the great saphenous or long saphenous vein that runs up the medial side of the leg. We'll meet it again in a few moments. And that joins the femoral vein in the base of the femoral triangle. The floor of the femoral triangle is made up of muscular structures. So on the medial side we've got the adductor longus and also pectineus, and more laterally we've got the iliopsoas muscle, though we don't normally need to concern ourselves with the muscular floor of the triangle. You've got the muscular floor, then the boundaries of the triangle, and then above that, and protecting the main vessels in the nerve, you've just got fascia and skin. So effectively the major vessels are quite vulnerable to penetrating trauma in this area. If we focus on the femoral artery, we can see that shortly after it comes under the inguinal ligament, it gives off a branch laterally, the profunda femoris artery, which is the main artery to the muscles of the thigh, of the upper part of the leg. And the rest of the artery carries on as the femoral artery, fairly superficially and down the medial side of the leg, before winding round towards the back, and as it does so, it goes through the adductor magnus in the adductor magnus canal, also known as Hunter's canal, fairly low down against the just above the condyle on the medial side of the femur, before it gets to the back of the leg, and more or less immediately goes into the popliteal fossa. If we focus on the profunda femoris, or deep femoral artery, we can see, and here's another diagram showing it, how this ends in a number of branches, all of which go backwards and wind round the back of the femur and give off a number of branches into the muscles, the hamstring muscles at the back, etc., providing arterial supply in the back of the thigh. If we look now at this diagram, which shows the lower part of the leg, the arterial supply in the lower leg, and start off with the left-hand panel in this image, we can see here the femoral artery as it's wound round medially around the femur, just appearing between the heads of the hamstring muscles at the top and becoming the popliteal artery, running down the middle of the knee before dividing just below it. And I want to focus on a branch that comes off laterally, which you can just see here, just before the final division of the popliteal artery. And this is the branch which perforates between the tibia and the fibula before becoming the anterior tibial artery, and we'll come to that in the second panel. So that's the anterior tibial going off, and then the popliteal artery continues and divides medially into the posterior tibial artery, and then the posterior tibial artery runs down the medial side of the lower leg in company with the tibial nerve before winding round the medial malleolus, and it forms the posterior tibial pulse. So when we feel the pulse just behind the medial malleolus, that's the pulse that we're feeling, the posterior tibial artery. The other artery that comes off at the origin of the posterior tibial artery is the fibular artery, which runs down more laterally. It's a smaller artery. We don't need to concern ourselves with it so much. It provides for a lot of the muscular supply in the back of the lower leg. If we go back up to the back of the knee and look again at that little branch going laterally in the middle of the knee, going laterally and then perforating between the tibia and the fibula, and then we move our gaze to the second panel, we can see that artery arriving between the tibia and the fibula as the anterior tibial artery, and then immediately heading down the lower leg in front of the intraosseous membrane. It's accompanied by the deep perineal nerve for most of its course before it passes under the extensor retinaculum, also known as the transverse crural ligament. So the two structures, the nerve and the artery, pass underneath that before entering the front of the foot between the first and the second metatarsal. And that is the artery, the anterior tibial artery, that we feel as the dorsalis pedis pulse just on the top of the foot. These four images describe the veins within the leg. In common with the upper limb, a lot of the veins run deep, often in conjunction with arteries. So in the same way as we have the popliteal artery, tibial, fibular arteries, etc., we've got corresponding veins deep within the leg. So various veins come together into the popliteal vein, which runs up the leg as the femoral vein before passing under the inguinal ligament. So that's the main deep vein structure. But this is joined by two important superficial veins. We've already met the long saphenous or great saphenous vein, which is a very superficial vein, which runs up the medial side of the leg before draining into the femoral vein just before the inguinal ligament. It's important in a number of ways. It's very constant, just anterior to the medial malleolus, and this is the site of venous cut down, where it can usually be found about 2 centimeters anterior and above the medial malleolus. It's also important as it's used a lot as a vein graft, for example, in coronary artery bypass grafting. It also suffers with varicosity, so if there's incompetent valves within the long saphenous or in the perforating valves that connect it into the deep system, so the blood is intended to be diverted from the superficial into the deep. If there's incompetent valves and there's back pressure into the superficial veins, then they may become dilated and tortuous, and that's the root of varicose veins, and that can affect the long saphenous. If we look to the third picture, this shows the short saphenous, which is the corresponding vein that starts on the lateral side of the foot, and that runs up fairly superficially in the posterior lateral aspect of the lower leg before penetrating the deep fascia and joining the popliteal vein. The second picture shows the combination of short saphenous, long saphenous, and the popliteal and femoral veins, etc., as they combine together before flowing up into the external iliac vein. The final image on the right-hand side shows the network of veins within the calf muscles. There's a pump action that takes place as a result of compression of veins within the bulk of the soleus muscle, and this is one of the important contributors to venous return from the legs during walking. Veins in the legs have valves, which helps to reduce the pressure within the lumen of the veins at the lower part of the leg. The valves enable the blood to be pumped up gradually by this action of the compression of the veins within the soleus muscle, and there's a rich network of veins there. Let's move on now to the muscles around the hip joint. Now there's a number of muscles, some of which we need to be aware of and some which are less important for us, particularly from an emergency medicine perspective. So starting off with this image here, which shows muscles, a lot of muscles on the right side at the left of the image, and then a cutaway view on the other side of the skeleton. And we're going to start off by talking about the adductor muscles. Now, just dealing with some of the smaller muscles that we don't need to be aware of, there are a number of muscles which are arranged fairly closely around the joint. A couple of them are seen here: pectineus, piriformis, the gemelli, obturator externus, obturator internus, which we don't need to concern ourselves about because they don't have an important contribution to the total power of movement around the joint. But they are closely aligned around the joint, and they're important in binding the joint together and holding it. And they also have fairly constant action in whatever position the hip happens to be in. Some of the larger muscles have more complex actions because they will have different actions. For example, iliopsoas will have different actions depending upon the position of the hip. But let's start off with adductors, those muscles which pull the leg towards the midline. And those are shown in the left-hand side of this image here. Of course, the biggest of those is adductor magnus, but then that's assisted by adductor longus and adductor brevis. And those are all shown here. They all attach the medial side of the femur. There's a line on which they attach. There's another longer adductor which goes below the knee, the others don't, and that's gracilis. And that inserts in what's known as the pes anchurinus along with sartorius, and we'll come to that when we talk about the muscles below the knee. But those are your main adductors. Now just note a couple of other muscles that we can see in this image. That's iliopsoas arising from the spine, and then on the left-hand side, tensor fasciae lata. And we'll come to those when we look at the other dimensions. But that's adduction. All of the adductor muscles shown in this diagram are innervated by the obturator nerve, so arising from L2, 3 and 4. This image shows the same hip as seen from the back. Now we won't concern ourselves with many of the smaller muscles, and we're just going to focus on 3 abductors. So these are the muscles which move the leg away from the midline, but actually in practice their main role is tilting the pelvis to enable the other leg to swing through without the foot hitting the ground. So that's their main function actually. With the active leg fixed, they tilt the pelvis up to allow the other leg to clear on the way through. And there's 3 muscles we need to know about: gluteus minimus, gluteus medius, and tensor fasciae lata. So gluteus minimus and medius both arise from the back of the iliac crest. Gluteus medius isn't shown here, but it occupies much of the rest of the back of the iliac crest, medial and superior to the area that the gluteus minimus comes from. And both of them insert over the tensor fasciae lata is actually better seen in the previous image. And here we can see it arising from the crest of the ilium, and it's a fairly short muscle and then a long tendon which goes all the way down to insert at a fairly distal point in the femur just above the knee. Coming to the flexors of the hip, there are 3 muscles we need to consider: the psoas, iliacus and rectus femoris. So psoas arises from the lateral side of the 5 lumbar vertebrae, L1 to L5. It converges and then inserts along with iliacus onto the lesser trochanter. So iliacus arises from inside the iliac crest, from a large area of the inside the iliac crest, and the 2 of them converge and insert on the lesser trochanter. Now, these 2 muscles are both flexors of the hip and internal rotators. And to see how that works mechanically, we have to consider where their insertion is with respect to the pivot point or fulcrum of the hip. So clearly they're lateral to that, which is why they're internal rotators, and they're also distal to that, which is why they're flexors of the hip. So those are 2 very important flexors of the hip. And the final one is rectus femoris. Now that's one of the 4 parts of the quadriceps muscle. The other three parts all arise from the femur itself, from the anterior and lateral and medial borders of the sides of the femur. But the rectus femoris, that particular component, actually arises from above the hip joint in the pelvis. It arises from the anterior inferior iliac spine, and then the rectus femoris combines with the rest of the quadriceps before inserting it into the patella. And so because of its function, because of its origin from the pelvis, it's also a hip flexor. Finally, the extensors of the hip. So these, in fact, are the most powerful component of the hip musculature because they're the muscles that drive the leg backwards, so propelling the body forwards. Gluteus maximus is an important component of this. It's the biggest of the buttock muscles, and it arises right round the crest of the ilium before inserting laterally in the proximal femur. That's gluteus maximus. And then the hamstrings, so that's biceps femoris, which is lateral, and then medial you've got semimembranosus and semitendinosus. They are also important hip extensors. They arise from the ischial tuberosity and then finally insert actually in the proximal tibia. And they have, because their origin is more posterior than their insertion, they have an action in extending the hip also. While we are focusing on muscles around the hip, it's a good opportunity to talk about some of the neurological tests that we can undertake by using leg muscles. And these are good multiple choice type subjects because they're easy to form questions out of. So when we come to testing power, these are the root values that we're testing. If we test hip flexion, then of course that's iliopsoas and a small amount of rectus femoris. Then we're testing L2, mostly from the iliopsoas, which are directly innervated off the lumbar plexus. Knee extension, that's quadriceps, that's the femoral nerve, L2, 3, 4, and that's largely L3, knee extension. Ankle dorsiflexion, that's through the common perineal, the deep perineal nerve, and that's L4. Great toe extension, also down through the deep perineal, that's L5. Coming to the back of the lower leg, ankle plantar flexion, but also ankle eversion, which is the superficial perineal nerve, and also hip extension are all S1 tests, and probably ankle plantar flexion is the one that's most commonly used to test S1 level. S2 is tested by knee flexion, so that's a test of the hamstring muscles. And then finally at the pudendal nerve is the anal wink, which is a test of S3, S4. If we look at this in terms of reflexes, the knee, as we mentioned, is a femoral nerve, arc, L2, 3, 4. So patellar tendon reflex is a test of those levels. And the ankle reflex, again, it's ankle plantar flexion, so that's S1.